All right, Joe, no more profanities because we're
What's that movie? The Bonfire of the Profanities?
no more bad jokes because we're recording.
We joined. Oh yeah, people. Yeah, the people coming on. So
Yeah. I owe Jen a Twinkie. She saved us.
yeah, thank God for Jen. Oh, I'll probably be a little late on Monday. I mean, on Wednesday, I have my COVID-19 vaccine.
Oh, good for you.
I got to go all the way to Newark, to University Hospital.
Yeah, I get mine on the 21st, my second shot. Then I'll be like a superhero.
I love it. I love it.
All right, how are we doing? Nope. Okay, folks, we'll be getting started in just a bit. Find my cursor. Ooh. Do, 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 do. What do you think, Joe? Give it a little more time.
Yeah, give them till 5:05, and then
You know,
we'll.
we're punishing the people who are prompt. That's what we're doing.
Let's see how many people are in. Virtually have half the people, so who signed up. Yeah, give them another minute or so.
Okay. All right, Joe, we better begin.
Let's go.
All right, folks, thanks for joining us. My name's Tom Bartholomew, and my partner is Joe Berkman, and we're from Rutgers University, the State University of New Jersey. And we've been doing a series on clinical supervision now for a couple of years, and we presented this material before. So if you've come to a previous one, you may find this to be very familiar. We hope to do more advanced sessions going forward once we make sure that people have seen the first, the number one, you might say. Has anyone seen this presentation before? Can you feel free to use the chat. For those of you unfamiliar with Zoom, down at the bottom, there's a button marked chat, and you can click on that and communicate with all of the attendees and panelists. But in the meantime, we'll get started. So the objectives for today, we're going to be talking about clinical supervision and what we call a best practice synthesis of clinical supervision, meaning it's not exactly a particular model, but it's really things from the literature that have been shown to be effective. We try to tie them together best we can. And we're going to start by looking at one of the common misconceptions about supervision, which is the difference between administrative and clinical. And a lot of people don't understand that. The next thing we'll look at is we're going to talk about the three functions of clinical supervision. And we believe these are the three functions of virtually all models of clinical supervision, which is a nice way to look at supervision in a more generic way. And then the last objective is we're going to look at how to promote psychological safety for supervisees. So if you're a supervisor, what would be your strategy to promote psychological safety? And we'll talk about why that's can be so important. So I want to start by doing just a brief exercise and kind of a warm up, and it's called a chaos inventory. And the way it works is, particularly now during the time of the pandemic and just our regular stress on top of the pandemic, it's not uncommon for us to experience stress in our lives and have it squirt out in a way that we're not always super aware of. So you might see it in the fact that you're cleaning more, or you're not cleaning at all, or you're overeating or undereating, or smoking more, or doing something more or less. And it may be a manifestation of the additional stress you're under. And so what I'd like to do is encourage you to write in the chat, how are you seeing the stress of your life play out in your life? And I'll give you an example. I find myself, I have a whole bunch of examples, because one of which is I find myself worrying more. So I have coffee in the morning, I'll be sitting there and I'll just be kind of filled with worry about things that normally wouldn't bother me, like a presentation like today. I do these quite a bit. But I really thought about this morning, I'm like, oh, got this presentation, and now I'm kind of into it. But there's an example of the way stress is showing up is I'm worrying more about things that normally wouldn't bother me. So how about you guys? Feel free to use the chat. Are you seeing stress in your life? Maybe in ways you don't normally, or maybe you always see the stress play out in this way.
Yeah.
Joe's my chat guy box, chat box guy. What do we see in there, Joe?
So we got some interesting. This thing was more smoking, less eating. Some people have more eating.
Yeah.
A lot of people are more tired, which is probably some of the stress that you're feeling. Less physical activity. Some people are playing more games. Dieting but not eating, not losing weight. That's probably comfort food. That's what I do.
Diet with comfort food.
Diet with comfort food. More anxiety. Yeah. More work focus. And no desire to do anything after work. It's interesting. I did a group, group the other day, and that came up. People who were going home and were feeling so terrible that they really got home, and it wasn't the panacea that they hoped it would be. It was just more stressful, and they couldn't, and they really didn't feel like doing anything. They said they just wanted to sit on the couch and just say goodbye to the world, and because I'm busy, not bother with the kids or the dog or the husband or the wife.
Yeah.
Waking up in the middle of the night. Yeah, absolutely. Yeah, and an unhealthy focus on work, where I was talking to someone at an agency who was saying that she doesn't eat lunch. She doesn't even have time to go to the bathroom. It's
Yeah, especially the Zoom train. Like so many people, if you're working at home, like I do, you can go from one meeting directly to the next. You don't even have to walk down the hall or do anything, you know. And it can be kind of brutal.
sometimes even going to work in the car. You can listen to music or listen to
Yeah.
books on tape and get a little time for yourself. Now you don't even do that. You go into the office oftentimes earlier than than anyway, because you're not factoring in driving.
So I appreciate that, everybody. I feel like I'm not so alone with with my stress in my life and the way it squirts out. Um, we do other presentations where we talk about resilience, and we talk about what are some strategies in the face of this the stress we're experiencing. And so if you're interested, there's the part 2 of this is when we talk about the restorative function of clinical supervision. We really dive into a bunch of models and ideas about how to build resilience. But in the end, it's a stressful time too. So we're not going to invalidate that experience. All right, so let's dive right in. You'll see more why we did the chaos inventory at the start, because it is part of what you can do in clinical supervision. To try and pull people in and give people a place where they can share freely. Okay, so when you think about clinical supervision, one breakdown that's helpful is to think about administrative supervision versus clinical supervision. And this famous social worker described administrative supervision as the promotion and maintenance of good standards of work, coordination of practice with policy and policies of administration, the assurance of an efficient and smooth running office, time, attendance, documentation, and logistics. All right, so you can see that these are the mechanics of the job: showing up on time, getting documentation in, and that certainly can be benefited by supervision and giving people feedback and setting standards, important standards, what's expected.
And these are often part of the traditional performance evaluation, in which a lot of the structured things that you do, a lot of the performance components that define your work and your work tasks are indicated.
Yeah, and what's really interesting is Joe and I did a couple studies here in New Jersey looking at the state psychiatric hospitals. And when asked if people do clinical supervision, they described administrative supervision. And the people receiving supervision said, yeah, that it's really administrative. And so let's define clinical. So for $25,000, what does clinical mean? Put it in the chat box. 25,000. Actually, I'm lying about that. I don't have $25,000, but I'd appreciate a response. What do you guys think? What does it mean, clinical? And I asked this as someone, I taught a class for many years called Clinical Principles in Psychiatric Rehabilitation. And for the life of me, I couldn't answer the question. I didn't actually know what the word meant.
All right, we have two good answers.
Okay, what are they?
Supporting our staff socially, emotionally, and professionally.
Wow.
And no idea.
Yeah, I'm with the no idea person. Any other? That one wasn't bad. I don't know if it's going to win the 25,000. Let's look at what's on the next slide. Dun, dun, dun. Can I get a drum roll? Can I get a drum roll? Oh, that's a crappy drum roll. All right. So I looked it up, and one of the definitions, the one I chose, was applying objective or standardized methods to the description, evaluation, and modification of human behavior. And what I liked about this definition was the idea that there's something objective and standardized. We're not making up the principles of psychology or behaviorism, but there's a real science to it. And this is what you learn when you become a clinician. You get a bachelor's or associate's, a bachelor's, a master's, a PhD, and you learn the science of mental health. So to me, a large part of what makes clinical supervision different is it is addressing the science of the work we do. And
even though you're not in a quote unquote clinical setting, you're not in an inpatient clinic or an outpatient clinic or an inpatient service, what you do still is, if you think about it, you're working with people and you're working with their behaviors and you're working with supporting and helping them to accomplish tasks and behaviors. So in many ways, clinical is not just the traditional health, but really has to do with what happens in all kinds of behavioral health programs and all kinds of housing programs. Because again, the person that you're trying to work with is that person, and you're working with them on those behaviors.
that's a really good point. I would go further and say that in permanent supported housing, you have the philosophy, right, of choice and autonomy and all of these things. I would consider those reference standards as well, that we're trying to do this work in a particular way. And the belief, of course, in permanent supported housing is outcomes are better if you do this, if you follow a certain programmatic philosophy. So we're not going to get way into it today, but in other sessions, we talk a lot about audit and feedback. And one of the biggest and most effective tools in clinical supervision is this idea of watching what somebody does and giving them feedback in a supportive and safe way so that they can make changes and move towards an ideal. And so we see this as a feedback loop where you want to set these standards and refine them. We call them reference standards. And then offer an audit of those standards, of the person's performance relative to the standard, give the person feedback, and then encourage them to make changes, and just you keep cycling through this loop. And the research suggests that the more frequent and safer the loop, the better you see change in the clinician, and they often really appreciate if done in a way that's intended as supportive and is supportive. It can be a really positive experience. So that's the distinction then between administrative supervision and clinical supervision. Clinical supervision, we're really talking about the interface between the work we do with clients and the philosophy and the science of it, whereas administrative supervision is talking about documentation and attendance and things that are very important, but they're just different in kind. So it does beg the question, or ask the question, is clinical supervision the best way to promote clinical excellence? And we've been around for years, Joseph and I.
Unfortunately.
Yeah, long time. And we've seen quite a bit. So let's explore some other ways. This has been extremely common in our field, and you're experiencing it right now, as a matter of fact. We're going to do this training, and then we're going to hope that it has a positive effect. And we see this with things like motivational interviewing and various forms of counseling, that someone pays for trainings, people go to the trainings, and they might leave really high on it. Like we call it a training honeymoon or a training high. But it really, the science is that trainings alone don't change clinical behavior very much. And it's been shown over and over and over. So trainings can be a part of changing clinical behavior, but they're not sufficient. And given the fact that you're in a training on clinical supervision, you can guess what we're going to say is, what is required. Okay, then another option is administrative supervision. Could we just be what we call transactional? There's the next slide, and really just just tell people that, you know, you need to do this, this, and this, and this, and this, and have them change their behavior in that way. And we see a lot of this in the large hierarchical system of the state hospitals in New Jersey. We call this also transactional leadership, which is the idea of just somebody is going to tell you what to do, and then you may tell someone else what to do, and on and on and on.
What doesn't work? What doesn't work about for this? What do you think doesn't work about the kind of Nike just do it kind of leadership? Anybody?
See the chat, yeah. Yeah, it's whoops, I banged them. It is interesting that there's things called stroke of the pen changes, which is like use this form and don't use this form. You know, file your reports here. Like in administrative circles, this can be effective depending on the nature of the change.
Yeah, good transaction is not often not connection. It does not allow for employees to showcase their strengths, and you don't experience doing it in real time. You know, in one of the articles talks about a bias for action, which I think is another word for initiative, but it's hard to give somebody responsibility when they feel like they are only doing what you told them to do rather than having learned the capacity to do it themselves. And in that case, to initiate the positive behaviors rather than waiting for you to tell them what to do.
It's a really good point. There's a strange term, and I'm sure you've heard it, but cybernetics. And if you've ever heard of a cyborg is a self-regulating machine, right? That can functions on its own. And one of the things Joe and I work on is what would make a clinician independent and capable of making complex clinical decisions, you know, as they move through their career. And it's not transactional leadership, right? That doesn't lead to an independent behavior, particularly not with complex clinical behaviors like cognitive behavioral interventions or something where it's really sophisticated and you just can't tell a person to do good clinical work and expect that to work.
And someone, as one of the panel, one of the attendees said, leaders also have to be effective listeners and inclusive conversationalists. Yeah, communication is a major component of good supervision. The capacity to be you know, some of the, again, active listening skills, or other things that you use in clinical settings with people who you're providing services to, those same basic clinical skills and those basic conversation skills are the same ones you need to be able to use with people on all levels in your organization. And that particularly includes your supervisees who you are trying to model for and demonstrate how to accomplish things.
Yep. So similar to, we just like this, the Chekhov syndrome, because of this next slide. Yeah, come on, got to give it to me. That's funny. So in many systems that Joe and I work with, there's a focus on outputs, the number of sessions, the number of visits, number of groups, versus outcomes. Like is anything actually changing, or are we just kind of cranking this stuff out? And then we consider that the Chekhov syndrome, where you just, you know, oh, did you meet? Yes.
And I got to tell you, one of the things about the Chekhov syndrome is there's a potential for ghost services. That is, there may be some structure to what you're doing, but the content and process of what you're doing, which are both important, just don't happen because you're looking not at outputs rather than outcomes.
Righto. So I won't belabor this, but people often think that clinical experience will confer onto people what they need to be excellent clinicians. We have not seen that in the state psychiatric hospital, in part because people they often don't see novel and innovative strategies for working with clients because they're so isolated and working by themselves. And there's been just a lot of examples of folks who, far from getting better, they really drifted into a place where they weren't very effective. In fact, the chair of our department wrote a chapter in a book saying experience is not the best teacher, and talked about all of the clinical biases that people can develop that can really keep them from growing. Joe and I are against what we call the private practice model, which is you hire somebody with credentials and they're supposed to just be good at what they do and do cutting edge best practice interventions. It doesn't always happen. Folks can get the credential and get stuck in doing what they did in graduate school and not take on new projects or new strategies. We also know that regardless of credentials, outcomes are not highly associated with credentials. They're really, folks with an associate's degree or consumers can produce very good results. You don't need an advanced credential necessarily. Okay, so we've talked a little bit about clinical supervision, but just very briefly, I want to review some of the evidence from the literature. Clinical supervision has been shown to improve staff satisfaction, and I would hazard to guess that the version of supervision we're going to be talking about today, we are talking about, would lead to this higher staff satisfaction. We see increased stress relief, accountability for services, increase in the knowledge base. There's increases in self-awareness, skill acquisition, use, improved knowledge of treatment. You guys can read. I shouldn't have to read this to you. But as you can see, the research suggests that there's a lot of good reasons to do clinical supervision and to make the time for it, because you probably agree with me. One of the most difficult things is finding the time to do this the way we all want to, or we want to try to do it. So it's a big pet peeve of mine. I wish I could get SpongeBob to actually be going imagination, but I couldn't do it. I couldn't figure it out. But this is from Derek Milne, a researcher in the area of clinical supervision. And he talks about there's hundreds and hundreds of models of clinical supervision that really haven't been scientifically explored. And so, yeah, they're high in imagination, but worryingly weak when it comes to evidence. So this is his definition of clinical supervision. It's a bit long. It's 2 slides. I'll warn you. I may have to move you so I can. So what he says, clinical supervision is the formal provision by approved supervisors, and I approve of all of you, by the way, so now you're approved, of a relationship-based education and training that is work-focused and which manages, supports, develops, and evaluates the work of colleagues. So that's a mouthful, but it's pretty well operationalized, right? So somebody said earlier in the chat, the idea of transactional leadership often doesn't lead to a good relationship. I've certainly seen that. But we're going to talk about these manages, supports, and develops as we go forward and talk about a best practice synthesis. So that's the first part. He goes on to say, the main methods are corrective feedback of the supervisee's performance. So that's that loop. Teaching and collaborative goal setting. So very much like what we do with clients, like you want to identify what's important to the client or to the supervisee. So it therefore differs from related activities such as mentoring and coaching because clinical supervision has an evaluative component. And that audit that we're talking about is part of the evaluative component, right? That you want to feedback information about the person's performance relative to the standard, and that's part of the evaluation. Clinical supervision's objectives are normative, restorative, and formative. And the reason I'm not getting any further into it is because we're going to look at that, break those out. So keep those in mind. Let's say that with me. Normative, restorative, and formative. I didn't hear anybody say it. I'm sure you're doing it at home, though. All right. So we're going to break in and talk. We're going to be looking at normative, formative, restorative. We're going to change the order. But Joe and I were curious about asking you guys, what is it? I believe you're all clinical supervisors. What makes clinical supervision hard for you guys? If you find it hard. If you don't find it hard, tell us that too. But use the chat function and just let us know what makes clinical supervision hard given your setting and the kind of work that you do. Oh, I'm really dark. Yeah, it's getting dark here. East Coast. What makes clinical supervision hard? I'll tell you, when I was a clinical supervisor, I'm gonna share while you guys share. What made it hard for me is I didn't know what I was doing, and I didn't know what I was doing for years. Meaning, I was a good clinician, I think, and I'm kind of a nice guy, I think. I want to be a nice person, but I really didn't know what I know now about clinical supervision. That's one of the reasons Joe and I got into doing this, is we wanted to help supervisors in ways to think about supervision. So what do we got, Joe?
Time, which is probably
Gotta be the number one.
number one answer.
Yeah.
Unfortunately, most agencies, and particularly in housing agencies where you're going from either place to place or meeting to meeting, and are talking to oftentimes to a supervisor in a different place. Time is a major issue. Being new to supervision. Yeah, most of us who've gone to graduate school maybe have learned a lot about our area of study, but rarely do they teach us how to be supervisors. And rarely I know in our hospital settings, they'll take someone from social work or rehab and then turn them into a supervisor all of a sudden without having done any supervision or had any training formally in supervision at all. Feeling what I am doing is helpful and purposeful for the managers I supervise. Yeah, and sometimes vulnerability actually works, and then sometimes letting them know that you're struggling too can also help with the relationship. Balancing the need for procedure with the needs of the employees. Yeah, and we're going to talk about that when we talk about the three functions. Identifying communication styles. Yeah, and how effective are your communication styles? And do you ever get any feedback on those? One of the things about supervisors, I think, early on, I probably did the same thing, but you're a little less able to take, I think, critiquing of your supervision because you're so uncomfortable with it at times that you're almost fearful of the feedback, and you'd rather not get it. So you sometimes get into this thing where I won't supervise you if you don't supervise me, or if you don't be a supervisor to me. So it's something to think about. Supervising multiple things in various elements as a company grows.
Yeah.
Yeah. And again, in most jobs, when they measure what you do, they don't oftentimes measure supervision and how much time or how much effort or how much you put into supervision.
It's a really good point. Also, fee for service, which is sweeping the country. They don't pay for supervision or trainings which is fascinating, right? All right, so yeah, that's interesting. I particularly resonated with the being new to supervision. I wish I had seen this series prior to becoming, or when I was a young supervisor, because there was an article that Joe and I read that talked about these three functions, which are what are coming up, and it was really transformative for me. Like, it really, really helped. So here's what I'm talking about. it was in the context of what's called the alliance model that we learned these three functions. But it isn't really the alliance model itself. We were impressed with these three things: the restorative, formative, and normative functions of clinical supervision. And we're going to talk about what these things mean. And it's convenient that they rhyme, frankly, because this guy, Alfred Kadushin from social work, he wrote a very popular book, still in print, on social work practice, a textbook. And he came up 17 years before these guys, Bridget Proctor, or her, and he said, he called them administrative, educational, and supportive as the three functions. That's what we're trying to do in clinical supervision. But because they didn't rhyme, he didn't get his name and didn't become as famous as Proctor, Bridget Proctor. All right, but we're not going to review Alfred Kadushin. We're going to move in to the three functions. Before I go there, this is one of the other things we discovered in clinical supervision, the balance between scrutiny and support, meaning does the supervisor feel like part of their job is to scrutinize and kind of watch for people doing the wrong thing, or are they supposed to be in the role of supporter, or both? And the reason I bring this up is because as we talk about these three functions, we're going to make the case that the primary role that we believe the clinical supervisor should be in is restorative. In other words, helping the person identify how to be well in doing this kind of work, how to stay well, how to stay restored. And that will form the basis for working on what's called formative, is the development of skills, forming new skills and learning, but in the context of feeling supported and validated. So this is the big trick, I think, at being a clinical supervisor. And then, of course, the normative is what are the norms of practice? What are the ethics and expectations in that regard? So I encourage you to keep this diagram in mind, that I used to think they were, equal parts, restorative, formative, normative, but I've come to believe that's not the case, particularly now during the stressful times we're living in.
I'm interested. How many people raise your chat hands if formative is, if you would describe formative as your most common function as a
Formative being teaching, the teaching
Right.
function, education function. I have to find my chat hand. I mean, my jazz hand. I have to find my jazz hand.
Oh, we could have done a poll too.
Oh, she got her hand raised. So Joelle and Jessica. Yeah, that's interesting. I would have said that before, I think. Now I've come down, particularly during COVID. I've been super sensitized to the need to work on, I'm calling it restorative, but it's a better word, resilience. Work on resilience in the face of the kind of work we do. And
Tina says she supervises managers, so she does more restorative work.
Interesting. At the managerial level.
The managerial level.
That's so interesting that she said that, because I run a group called Meta Supervision with supervisors. And there's 8 supervisors of 8 different programs. And they lap up the restorative stuff, because I think they're so squished between leadership and the subordinates. They really need, that's a really interesting point. All right, so let's, I apologize for kind of talking about them without defining them clearly, but here, let's do that now. So the 3 functions, again, are restorative, formative, and normative. Restorative, formative, and normative. So the restorative function, the one I'm saying is, I think is maybe the most important and forms the context for the other 2, has to do with supporting emotional processing, promoting reflection. This is also called mindfulness. it's or reflective practice. The idea of reflecting on what it is you're doing and how do you feel about what you're doing. How do clients make you feel? Not that they make you feel anything, but how do you feel with certain clients? Do certain clients press your buttons? um, Supporting personal and professional growth. And it also includes team building and sometimes just the restorative exercises that we do in supervision are themselves team building. I think this is one of the number one things that an organization can do to help build resilience of its staff is to give them a place to talk about self-care and what's working for them and to support one another.
You know, President Biden talked about building back better, and kind of resilience is all about bouncing back.
Yeah.
How to increase a person's self-awareness, how to increase their self-care, right? And taking care of themselves,
Yeah.
and really being able to provide feedback and kind of focus on their relationships and what they do.
It's a good point. In other sessions we talk a lot about staff burnout and how we often use the term burnout as I'm like so burnt out with coffee or burnt out with it. But really, burnout as a syndrome is pretty terrible. People are really suffering. And so we think that the restorative function in clinical supervision is one of the major weapons against burnout.
Yeah, it's relational. It really is the relational piece. And I think in many cases, I believe it's probably the most important of the functions
Yeah.
because I think it makes it possible for people to hear the normative and the formative. When I'm able to communicate effectively with you, then I can talk about process and I can talk about performance in a way that can be heard and shared and received in a non-defensive way.
Yeah, Joe, you make such a good point. And we're going to talk a bit more about that quality of the restorative function, that if you feel like you can be vulnerable, you're more likely to take feedback about the audit, right? That, somebody's going to be watching what you do and give you feedback. And if you become super defensive, it's just not so helpful, right? And of course, it can always sting a little bit whenever you get constructive feedback. But at least in my experience, some of my best learning experiences were painful and that I needed to hear them. All right. So I mentioned restorative, formative, normative. So the formative function has to do with it's a teaching function, educational function, and it includes all of the clinical competencies. And Joe and I talk about clinical competencies as KSAs, or knowledge, skills, and attitudes. So there are knowledge competencies, skills competencies, and attitudinal competencies. This formative function, I think about it also as helping to form the culture of the agency. So to talk about what's important in the agency, what values are we subscribing to? Are we being respectful of clients in the meeting when they're not there, when we're talking to one another? Or are we just ripping on them and that kind of thing?
And we should mention, Tom, that in terms of that, think about what your agency is like. Is your agency more formative, more restorative, more normative? And what impact does that have on you and how you function as a supervisor? What do you want from your supervisors and how does that translate into what you provide to your supervisors?
Joe, you're good, man. I've never heard you say that before, and I've heard everything that you've ever said. Yeah, it's a really good point. Absolutely. All right, so sticking with the formative function, as I mentioned before, some of the best science as it relates to clinical supervision has to do with this thing called audit and feedback. This article by Ivers was part of a Cochrane review, and Cochrane, the reviews are like of the best science in that we have, and this is the best science in psychology. And so it was 141 randomized controlled trials found that this strategy of using audit and feedback, auditing the practice, comparing it to a reference standard, and feeding back the comparison was really, really helpful. But it has to be done in a supportive way. It can't be you're trying to rip on the person. I think about it as like if you were going to teach me to swing a golf club, and we were friends, that's the kind of energy that you want. That you're trying to help me be a better golfer and not to hurt me in any way.
Yeah, Carol says feedback's a gift, especially if it's delivered correctly.
Yeah.
To make it timely and specific, probably I'll tell you, one of my pet peeves is you did a great job.
Right.
Because I don't know what that means, and I'm not sure how much it helps me in the future. It's just not specific enough to really elicit a response from me, and to know what did I do well. So it's something to think about. Better than not than giving negative feedback all the time. And a lot of supervisees, at least in the state hospital, one of their complaints is that they're always told when they've done something wrong, but positive feedback is kind of oftentimes hard to come by. And I think the ability, particularly now, as I think about the pandemic, and as I think about all the stress, being able to check in more often with your supervisees is really a good thing, I think. And in addition, making sure that during this time where they've had to maybe assume additional responsibilities, that they understand what those responsibilities are.
Yeah, it's a good point. I'm struck there was a term in the clinical supervision literature called a tyranny of niceness. All right, so you have supervisors that are just kind of always giving constructive feedback or negative feedback. But there's also supervisors who are just overly nice. And I think I fall into that category where I don't give the constructive feedback because I want to be liked and I want to be nice. But I really shortchange folks who need that feedback.
Yeah, and one of the attendees said, positive feedback is a great way to reinforce the behaviors we want to see in our staff.
Nice, absolutely.
Absolutely, it's that modeling piece that is so important. Oftentimes, if you're treated poorly, it really impacts you and can very well impact the people you work with as well.
Yeah.
So we're continually, and that's why we're continually, as part of these functions, continually wanting to help people to be more reflective and more self-aware of what they're doing. Again, going back to the whole communication issue, the idea is to be aware of your own behavior and to help your supervisees be aware of their behavior, because it does impact relationally what goes on with the folks that you're providing service to.
Hey, in that spirit of the person who left that comment about positive reinforcement, let's all challenge ourselves over the next week. Let's give somebody positive reinforcement for something they've done, right? Because it really makes a huge difference. I really react positively when somebody points out something I've done well. So let's set that goal for ourselves. It's a challenge, a stretch. All right, restorative, formative, and normative as the three functions of clinical supervision. So this third and last function, the normative function, is called the accountability function. And in that sense, it's not the sexiest of the functions, but it's really important. I think of it also as the norms of what the evidence is for effectiveness, right? So I lump into, yes, ethics and and organizational norms, but also we have part of the norms of practice are that we don't use primal scream therapy with somebody with anxiety. That's just a bad idea. Ask me how I know. But there's a lot of things that we shouldn't be doing as clinicians, and that's part of the normative function, is to stay aware of current practice and stay in line with current practice.
Yeah, and Tom talked before about clinician bias and the fact that sometimes um, I've seen people who uh, are very who really garner what they know about people uh, from their own experiences and their own biases rather than being non-judgmental and responding to people in terms of what the uh, problem problems are. I mean, did you ever hear someone say, "Oh, gee, that was person's got a personality disorder"?
Me?
You talking to me?
You talking to me?
Uh, but so I think it's important. And again, accountability is one of the things that you'll find in your performance evaluation, right? Um, were you always late? Were you always paperwork was always late? Were you uh, not able to get to your meetings on time? Were you
Well, Joe, you're making a really good point that the normative function is the intersection of administrative supervision. It's other
Mhm.
things, but it's right that you can't be successful with a client if you miss the appointment, right? And we won't get paid if you don't do your documentation. And so really is critically important. It's not sexy, but it is really important.
Right?
And I hate to say this, but I was a director of a program for many years, and sometimes you had to let somebody go that was a really good clinician, and they just had some other flaw, like they just couldn't show up on time or do their paperwork, and it's sad. All right. So restorative, formative, and normative. This is one of the big tensions in clinical supervision in the literature, and that is between psychological safety and accountability, or between the restorative function, which is we're there to be supportive and helpful, and we're here to hold you accountable, right? And there's no simple answer to this tension, but this is what clinical supervisors have to deal with. They have to resolve this the best they can. And we're going to offer some suggestions. So there's a tension between the restorative function and the normative function. So I just put this slide in before this training. Somebody asked me, like, what is it? What do you mean by psychological safety? So the tension between psychological safety and accountability. So I just got this off the web. Psychological safety is being able to show an employee's, you're kind of in my way. Show and employ oneself without fear of negative consequences on self-image, status, or career. So I'm going to show my true self. It can be defined as shared belief that the team is safe for interpersonal risk-taking. In psychologically safe teams, team members feel accepted and respected. That's pretty good. Really pretty good. I mean, this is what we mean by psychological safety, that that you're safe to say how you really feel and what's really going on with yourself.
What do you think that mean? How do you think that affects your supervision?
People have said in previous sessions, and feel free to go in the chat, what do you think about this idea of psychological safety? But people have said in the past, supervisors have to be careful. Like, supervisors can't get their needs met with their supervisees, which I agree completely. But we can share what's going on. And for example, I shared with you guys that I'm worrying more. And I don't think there's anything wrong with doing that. I'm not trying to meet my needs through you guys, but I'm modeling a willingness to be vulnerable. And that produces a psychologically safe team, right, is the willingness to be vulnerable. Is anybody riffing on the psychological safety idea?
So far, no one is psychologically safe enough.
So it's not in this presentation, but I've been doing reading on this concept of like what makes a psychologically safe group. And I would have said that if the group is safe, then people will be willing to be vulnerable, right? I thought it was in that order. And what the research has suggested is it's actually the opposite, that if you're willing to be vulnerable, the group will be perceived as safe, right? If somebody's being vulnerable, like when you heard me say that I'm worrying more, you likely felt safer and more willing to kind of say, yeah, like, and I'm not eating, or I got this issue or that issue.
Yeah, and that's really important because, particularly at this point in time when stress is higher, oftentimes people do feel funny about going to somebody and saying, "You know what? I'm really stressed out. I'm really having a tough time." And what that does is it prevents people from being able to get help, um, so that they can still do their job, and feel effective and still feel cared about. Uh, I'm pretty much me most of the time, though my company does allow us to be ourselves.
Good.
Yeah, and again, that vulnerability helps you to feel. It helps your supervisee, um, to feel that relational kind of that relationship, uh, is a positive one, and I think it also kind of moves it to a more equitable place. Um, you're still their supervisor, that you're still going to have to provide them with, uh, direction, etc. But, um, the capacity to also be there, as a human, quote unquote, support, I think is really, important. And what it most likely will do will engender them to be able to talk to you more and to share stuff, and to even take some creative risks that I think are important to practice.
Yeah, it's a really good point. In part 2 of this series on the restorative function, we go through a whole bunch of exercises that we routinely do, and we literally do this all in every supervision, that we do to promote not only psychological safety, but resilience and promote reflective practice. So some of the exercises are, we'll do a round and we'll talk about self-care, which is say, how are people doing with self-care? Does anybody want to share? And you can always pass, of course. And then for people who say like, oh, I'm really not doing great, I'm actually the opposite of self-care, whatever that is, self-harm. They might do a stretch where they agree, like, I'm gonna start reading again, and I'm gonna report back to the group and let you know how I'm doing. It's been really, really positive experience for us. And of course, you always got to be a little careful. I understand, but on balance, it's been the secret sauce, I think, for our clinical supervisions. All right, so here's a pro tip. Because of this tension, because it's so important, this idea of this tension, I think, between the normative function and the restorative function, that if it's possible to separate the support function from the normative function, in other words, can you have a clinical supervisor who is not also the administrative supervisor? Or can you have peer supervisions where there is no person that's hierarchically above? It's not always easy to do, and small organizations maybe can't do it. But we've been successful in the state hospital system because it's so big. We were able to bring supervisors together that and not have their boss in the room. Fantastic. Now, it can be done without it, as absolutely. And you guys strike me as a particularly cool group of people. So I think if anyone can do it, you can. So we just have a few more minutes, Joe.
Yeah, are there any questions, any
Or comments.
comments that people have about anything that we've talked about.
Anyone out there suffer from the tyranny of niceness? Huh? Joe Berkman wouldn't tell you, but he does.
Yeah, absolutely.
You know?
Will slides be shared? Yes, slides will be shared. You'll be able to get them.
They go right to Kimberly Castle with this
Kimberly
link.
Castle.
And we're recording too, so if you've been swearing, you shouldn't have been because we're recording. Yeah, we'll send you this. And you'll see a list of future presentations that really break down the functions in more detail and give concrete examples.
And I'd like for you to start thinking about, one of the things that, because it's kind of almost an adjunct at times, start thinking about some kind of supervisory improvement plan. Something that you would like to get better at as a supervisor. We often talk about in-service trainings around, lots of different issues, but rarely are there supervisor in-service trainings around around supervision and supervision skills.
That's a really good point.
So being able to develop your own plan for development, and even to share it with your supervisor, or even to ask of your supervisees, it's a real good way of making supervision a much more alive and much more a part of the work you do in the agencies.
Yeah, I think that's a terrific idea. So that's it for us. We've used up our time. Remember, you have homework. It's to give positive reinforcement to someone who deserves it. So we're not just blowing smoke.
Thanks, Celia.
And if you want to send it my way, I'm totally fine with that.
Oh, hold on. Sent an email to staff during the webinar. I hope it was positive. Hope it was good.
Oh, you did? She did. Oh, that's great.
Look at that.
That's nice.
Well,
Oh, that's
right. Boy, that's you're not a procrastinator at all.
No.
Very appreciative and vulnerable. Thank you for the reminder. Great. Yeah, great. It's a very tough job being a supervisor, because it oftentimes is not your only job, but it's part of a much larger and greater responsibilities. And it's probably the one you get the least, I think, support around. And I think the least help with.
So on that note, I think you guys are doing a great job. I don't know for certain, but it seemed great to me. So thank you so much for attending, and we hope we'll see you again real soon.
Stay well, stay unstressed as you can.
Yes. Thanks, guys.
And be resilient.